How do we dose insulin? This is a very important topic because often we see insulin dosing that inhibits the patients from getting healthier. Remember how the pancreas secretes insulin in two ways, basal insulin and bolus insulin. Our insulin prescriptions should reflect what physiology does normally. So most patients, if they are on more than 20 units of insulin per day, they need both basal, long-acting insulin, and bolus insulin, short-acting insulin, to be given at meals. A patient's starting insulin dose should be their weight in kilograms divided by 2 as their total daily dose. Half of their total daily dose should be given in basal insulin, and half of their total daily dose should be given in bolus insulin, split throughout the day with their meals. So, for example, if a patient weighs 60 kilograms, their total daily dose of insulin should be 30 units. Now, we split that into basal and bolus. So half of that 30 units should be in basal, so 15 units of basal insulin. The other 15 units should be in bolus insulin with meals. So let's say they eat 3 times a day. They should be given 5 units of bolus insulin 3 times a day, 15 minutes before they eat, for a total daily dose of insulin of 30 units. More often than not, we see patients that are over-basalized, patients on very high doses of basal insulin and no bolus whatsoever. This will lead to one of 2 scenarios. Either the patient will be well controlled as far as blood sugar in the morning and high throughout the day, or they will be well controlled during the day and low overnight in the morning when they're fasting. Over-basalizing a patient will never lead to good control. We need to give patients physiologic doses of insulin with both basal and bolus insulin. When a patient is on less than 20 units of insulin, though, they may be able to get by with other non-insulin agents such as GLP-1 receptor agonists that work at mealtimes, or metformin, or glinides that can work at mealtimes.
Determining our patient's insulin dose can be overwhelming when we don't have a systematic approach. What we see too often is that patients are getting over-basalized. This means that they are on a high basal dose without any bolus insulin. This leads to hyperglycemia and hypoglycemia and never really leads to good control. When choosing a patient's insulin dose, a great starting place would be determining their total daily dose, which is their weight in kilograms divided by 2. Half of their total daily dose should be in basal insulin, and the other half should be in bolus. For example, if a patient weighs 60 kilograms, their total daily dose will be 30 units of insulin. 15 units of that will be in basal, and the other 15 will be in bolus split with meals, so 5 units TID AC.